Measuring the arterial oxygen saturation by pulse oximetry using a fingertip sensor is commonly used in the management of CF patients. Transmission pulse oximetry is a non-invasive, accurate, and simple means of monitoring oxygenation, but this technique has some drawbacks. It can fail in accuracy when low arterial oxygen perfusion occurs. It is sensitive to mechanical artifacts caused by movement of the sensor. However, new pulse oximeter design using the signal extraction technology, or the SET, has been demonstrated to improve performance during low perfusion states and patient motion. Oxygen saturation results determined by pulse oximeters of different brands are often not identical. In this video, we will investigate the influence of digital clubbing on oxygen measurements. The measurements are obtained using a fingertip sensor at the right index. Example of the transmission pulse oximetry and multi-site sensor at the forehead. Example of the reflectance pulse oximetry. Finally, an ear sensor at the right ear transmission pulse oximetry is applied for having a reference variable in comparison with the other two measurements.
Using the Bland and Altman method in Figure 1 and Figure 2, there is no clear difference was found between the SpO2 measurement of the right ear versus the forehead sensor in Figure 1. The trend line cannot be distinguished from the x-axis. The two figures have the same scale. Figure 2 shows non-clubbing group a trend line, which again cannot be distinguished from the x-axis. When the measurement of right ear versus the fingertip sensor are compared, on the contrary, for the clubbing group of a very clear trend line is seen.
Even the removal of the outliner essentially provided the same result. The dotted line indicates the standard deviation of the difference in percentage saturation. The trend line also shows that the difference in saturation becomes greater as the saturation measurement at fingertip is lower. This can confirm that there is a significant difference in measuring oxygen saturation at the right fingertip in contrast to the measurement at the right ear of CF patients with clubbing.
Median age of Group 1 was 14.6 years with a range of 7 to 22 years old. Mean baseline was for VC is equals to 96.9%, FEV1 is equals to 90.1%, MEF25 is equals to 73.7% of the predicted values. The mean DPD to IPD ratio is 0.88 with a range between 0.83 to 0.92%. The median age of Group 2 was 19.1 years with a range of 10 to 32 years old. Mean baseline was for VC 68.6%, FEV1 is equals to 49.2%, MEF 25 is equals to 20.6 of the predicted values. Mean DPD to IPD ratio is 1.8 with a range of 1.06 to 1.15. The one sample Kolmogorov to Smirnov test showed that the SpO2 measurement of the forehead, ear, and right index in Group 1 without clubbing as well as in Group 2 with clubbing are normally distributed. Results are shown in Table 1.
So we found evidence of a clear difference in oxygen saturation measured by the pulse oximetry between the measurement of the right index and the forehead in cystic fibrosis patient with digital clubbing. So no difference were found in cystic fibrosis patient without digital clubbing. So ideally, we could also have looked for a correlation between the degree of digital clubbing and the difference in oxygen saturation measured at the forehead and right index. Therefore, we should have measured the DPD and IPD ratio by making a solid plaster cast of the right index of each patient, measuring the distal phalangeal depth and intraphalangeal depth with a micrometer. However, this was considered to be inconvenient and very time-consuming to the cystic fibrosis patient at that time. Therefore, we used the skin caliper, giving us an immediate but less sensitive indication of the degree of digital clubbing.
Arterial blood gases measured after arterial needle puncture remain the gold standard for assessing arterial oxygenation. However, this method is invasive and difficult to repeat, frequently, especially in young or very ill patients. Therefore, a non-invasive and practical method in the CF patient daily treatment, such as ear sensor measurement, must be preferred as reference. Variable presence studies showed no difference between the result obtained from reflectance oximetry measured at the forehead and those from the transmission oximetry measured at the ear. On the contrary, in literature, the reflectance oximetry method isn't considered as accurate, reliable.
This study reveals the ignored fact that digital clubbing compromises significantly the registration of the oxygen saturation on the extremities with underestimation of the saturation. Adjusting the oxygen level by administrating oxygen based on the oxygen saturation measurements at the extremities in CF patients with digital clubbing can result in an excessive oxygen supply, leading to carbon dioxide retention.
Theories regarding the pathophysiology of digital clubbing in various diseases such as neural, vascular, and hormonal mechanisms, but none of them produce a unifying explanation. Digital clubbing is a result of hypertrophy of connective tissues and increased vascularity of the distal phalanges. Most recent knowledge suggests that clubbing develops due to the presence of bioactive substance in the systemic circulation, which is either overproduced or poorly eliminated by the affected organ. Based upon these findings, a perfusion problem at the peripheral site can be a presumable explanation of our results.
Conclusion: we've noticed a possible underestimation of saturation as measured at fingertip in CF patients with marked digital clubbing. We recommend that oxygen saturation should be measured by transmission pulse oximetry with a multi-site ear sensor in patients with digital clubbing.